Okay, hi, good morning, everyone. First of all, I would like to thank Dr. Kyril for the informative talk just now. So mine is actually much simpler. So first of all, I will present on this screening and workflow in emergency department hospital Kuala Lumpur. Of course, COVID patient can present to either ED or any fever center, or some patient may even come to our green, we don't know. So this is if the patient are stable, okay, the EDMO will actually need to assess the patients for Paxlovid eligibility. So this eligibility, of course, any patients that come in with COVID, you all can get the form, which I will share later. So the form I will keep in emergency department. So just now, I think Dr. Asman suggests to keep in the con room lah. So any patient that come in, we actually need to fill up this HKL Paxlovid assessment form. So the criteria are the same as mentioned by Dr. Kyril just now. So adult, of course, more than 18 years old, within 5 days of illness, not requiring oxygen, not pregnant, not breastfeeding, creatinine clearance above 30, no severe liver impairment, and we need to check the drug interaction and the Paxlovid score more than 3. So after EDMO screen for the eligibility criteria and patient is eligible, then you guys need to contact EP on the floor lah. Okay, to authorize the prescribing of Paxlovid. Okay, so then EP will review the patients again and confirm the eligibility, and then the EP will prescribe the Paxlovid, or MO prescribe, EP will need to countersign. Okay, so after EP countersign the prescription, you guys can actually call the pharmacist, because now we are in emergency department, we are only going to start during office hour only. Okay, until 5 o'clock. So any cases from 8 a.m. to 5 p.m., if there are patients, you can just straight away call the pharmacist, either me, Paula, or Queen. I mean, those that juggle ED zone in main block. For fever center, can call me Steffi. Later, I will share the contact. Okay. Then for pharmacists, we will collect the form. Okay, we will do the bedside dispensing to the patient, and we will counsel the patient. Okay. So this is the flow for ED. I will share in the ED group later. So this is the HKL Paxlovid assessment form. So compulsory to fill in all necessary information. The first part is, of course, the patient's detail lah. Okay, name, patients from which zone, full IC number, age, address, and contact, very important. But of course, now we got the sticker. You can just paste the sticker there, got all the information already. Okay, it is sufficient. Then patient's body weight, serum creatinine, and creatinine clearance. Okay, creatinine clearance actually by product labels they use CKD ECI formula lah. But if you want to calculate using Pocrocod, also not an issue. We accept. Then for diagnosis details, category very important, only 2 and 3. If patient coming cat 4, tak payah lah. Then days of illness, I mean the symptoms onset, day 1 ke day 2, day 3, day 4, atau day 5 kena tulis lah. Then patient whether will be hospitalized or not. Okay. Then date of admission, date of discharge, if the same day, actually sama sajalah. Then this is a screening for contraindication. So when patient came in, come to us. First of all, is screening for contraindication. If let's say you know the patient is less than 18 years old, you know it's a contraindication, tak payah start dah. So you don't need to call pharmacist anymore. You just tick, then you just attach the form in the BHT. That's it. Because you know contraindicated already, or symptom more than 5 days, COVID cat 1 or more than 3, patient require oxygen, all this, we screen for contraindication first. Then we can straight away exclude the patient. You don't need to do further assessment for Paxlovid anymore. Okay. So if let's say patient don't have any contraindication, then you go to the scoring for eligibility, as explained by Dr. Kyril just now lah. So here, patient's age, the severe immunocompromised condition, all are listed out in the form. Okay. Then patient's CKD status, comorbids, everything is here lah. Okay. So you can write the total score here.
Can I just add on dekat vaccination status tu, kalau kita kat situ unvaccinated due to medical reason.
Yeah.
Kalau you tengok in the guideline kat PCM4, memang dia specify kat situ due to medical reason why patient are vaccinated. The reason why, because they don't want to offer this. I would say they don't want like they try not to offer for unvaccinated because of personal reason, only for the anti-vax lah. But anyhow, we don't see as many yang tak vaccinated because of medical reason. But then that day we had a discussion in our pharmacy and all. We decided that for us, because we have 3,500 patients worth of pills, if they are unvaccinated, regardless what the reasons are, we just score them as 2. But it's a fine line, differentiate kan. If the reason is because of personal reason, religious reason, we don't know. Kan? So if as long as they are unvaccinated, then we just score them as 2.
Okay. So next one, screening for drug interactions. If let's say patient is eligible, then we have to move on to screen for drug interaction. This is very important. We need to get the history from the patient, where the patients follow up, whether from EDHKL, from clinic kesihatan. For this drug interaction, I mean, if let's say patients already eligible for Paxlovid, the first thing, call pharmacist first, so that we can work together to speed up the Paxlovid dispensing. Okay. So for this one, mainly will be done by the pharmacist. Definitely, we will trace all the medication and check for any drug interactions. Then we will discuss whether patient is eligible or not. I mean, based on the drug interactions criteria. Then after that, prescribing of Paxlovid. So does the patient fulfill all the eligibility criteria? If yes, then you just choose one of it, whether criterion clearance above 60 or 30 to 60. Then next one, the next page is for pharmacist use. So after the doctor settle the top part, then we will fill up this. So pharmacy will screen again whether patients fulfill all the eligibility criteria, and then who is the prescriber. CP1 is our medication history. So if let's say we already obtain the patient history, then we will check here. Then we will check for the drug interactions. We will do the counseling and any identified issue. Okay. And then monitoring, and then for the KKM requirement, we actually need to monitor the patient's day 3 and day 5. So this will be done by the pharmacist as well. So mainly we will contact the patient. So patient's contact is very important. Okay, so we will need to contact the patients whether they got any missed dose. Because this drug is very expensive, you don't want them just to take it and then they don't take the medication. Yeah. And then we will also ask for monitor for any adverse effect during that 5 days of treatment. Okay, whether patient are worsening, admitted to the hospital after taking the Paxlovid. So all these we will actually from pharmacy side we will follow up this patient. Okay. Then the next one. Okay, next one is this is the packaging of this Paxlovid. This is the actual packaging. So one box is for one course. Okay, one box is for one patient. So one box actually got 5 strips of this 5 strips of this medication. So this is for AM, this is for PM. As you can see, actually got 3 tablets here. 1 tablet of ritonavir and 2 tablets of nirmatrelvir. So morning cost 3 tablets. Afternoon dose is also 3 tablets. Then for renal adjustment, we need to reduce the dose. So it's only 150 milligram of nirmatrelvir plus 100 milligram of ritonavir. So when dispensing, pharmacists will actually cut down this medication. We will cut it out. Okay.
Then the remaining one you use for?
We will keep in the pharmacy first in case other lost drug or other supply in the other missing as a backup. This is how you write the prescriptions for Paxlovid. Kalau pakai outpatient PS, for criterion clearance above 60, you can just write Paxlovid 300/100 BD for 5 days. Of course, patient's details need to be complete. And kena ada EP punya sign Okay, this is 30 to 60. Then kena tulis Paxlovid 150/100 BD for 5 days. So kalau ada case nak start, call terus district, one of district. Kalau fever center, call Steffi. Another way of writing this prescription, kalau rajin, nak tulis full generic names pun boleh. Nirmatrelvir 300/ritonavir 100 Okay, next I will go to the drug interaction. I think this one easy speed. This drug ada banyak drug interactions. I just take from one of the reference Okay. For this one, rifampicin, patients kalau TB patient, straight away tak payah pakai Paxlovid And then alpha-1 blocker, if you see here, this is usually for BPH patient, just suruh kita hold. But of course, these type of cases, whether to hold or not to hold, I think you call the respective punya doctor, patient punya doctor, or refer back to Euro. If let's say patient are still in the emergency department, I mean to get their input lah, whether to hold or not to hold lah, because this one need to weigh the risk and benefit.
The most common is Prazosin.
Oh tak, Prazosin no interaction expected. Prazosin tak ada.
So amiodarone tak boleh.
Amiodarone patient on amiodarone tak boleh. Yang I highlight is a common medication yang we see in the emergency department lah. And then anti-epileptics, tak boleh lah kalau patients on carbamazepine, phenobarb, phenytoin semua tak boleh pakai Paxlovid, except patients solely, I mean only on epilim, then boleh. Kalau dia on single anti-epileptics, epilim saja boleh. Kalau dia ada combination, semua tak boleh. Then antipsychotic is also another tricky one. Ada yang suruh reduce anti-psychiatry by 50%. Like some drugs like clozapine do not use Paxlovid. I mean for psychiatric patient, this one also very tricky. It's better to consult psychiatrist first lah. Then for benzo jarang, but also I mean like clobazam, clonazepam is like in seizure patient, I mean epilepsy patient also sama juga, here use with caution. Alpra and diazepam pun sama juga. Then CCB like this one, only amlodipine dia mention reduce dose by 50%. Kalau patient 10 mg we reduce by 5 mg, kalau 5 to 2.5. Tapi the rest like diltiazem, felodipine, nifedipine, verapamil semua dia tak cakap. For example, patients on felodipine, there's a all this possibility of hypotension atau bradycardia later. So if let's say the patient on this medication, dia lepas ambil Paxlovid dia kena balik HSO, tapi katakan dia tak ada BP monitoring set dekat rumah, tak ada orang boleh jaga. I mean this can be dangerous to the patient also. Yeah. So let's say we start Paxlovid for patients on this medication, we really have to counsel the patients, ensure they have a proper monitoring equipment at home lah. Kalau dia BP monitoring pun tak ada, then really have to justify lah. I mean the risk and benefit of starting Paxlovid for this kind of patient. Another issue is that katakan patients hypotensive, katakan dia ada what do you call that? Dia on felodipine for example, hypotensive, then we have to refer back the patients back to the hospital lah. We have to tell them to come back to the hospital. Then it's another issue whether to complete the Paxlovid or not. Yeah, or withhold the hypotension, the antihypertensive straight away lah. So it's not just patient ni bukan sekali bagi je dah end story. Actually tak ada. Quite a lot of things to follow up. And this drug-drug interaction can actually, we need to modify the drug and dose for actually 8 days, total 8 days, because the drug kita bagi course of 5 days. Tapi the CYP inhibition, dia need another 3 days to wash off. So katakan patient kena withhold drug ke, kena reduce dose ke, the original dose, dia kena ambil balik original dose on day 9 actually. Some say day 8, some say day 9 lah. So to be cautious, day 9 lah. Then patient on anticoagulant sama juga. Kalau apixaban, rivaroxaban boleh, dabigatran boleh. Satu je boleh. The rest ini pun kena reduce dose. This is a bit hard also. Kalau suruh patients reduce the apixaban. Inhaled corticosteroid, I think should be alright. If let's say increase, systemic corticosteroid exposure, just a short duration, it won't cause any Cushing or anything. I don't think so. Yeah. Or adrenal suppression pun require at least 21 days, so I think it shouldn't be a problem lah. Opioids, I think this one jarang juga. Kalau outpatient jarang dia tak ada fentanyl. Yeah, and we don't use for patients and cat 4, cat 5, so this one shouldn't be a problem. Then clopidogrel dengan ticagrelor pun sama. Kalau patient recent ACS, baru je kena non-STEMI last month ke atau last week ke, of course we cannot start patients on Paxlovid lah. Katakan patient on dual antiplatelets sudah dah genap 1 tahun, maybe can consider Paxlovid for this kind of patient. Yeah, still need to assess between risk and benefit lah. Because for clopidogrel dia kan the AUC of clopidogrel akan reduce by almost 50%. Dia akan jadikan clopidogrel useless actually. And then for ticagrelor is a reverse, dia akan increase the risk of bleeding because the ticagrelor punya exposure akan double up. Yeah, one is bleeding, one is reduced effectiveness lah. So yeah, the common one. And then PDE5, ni kena bagi tahu lah, patient usually kalau HSO tak akan makan this type of medication, but we still have to tell, especially for male patient. Then for statin semua kena withhold. Atoa, Rosua, simvastatin. You have to tell the patient.
Atoa, you have to cut some
if they can cut lah, doctor. If let's say we give 20 minutes, they can cut, but I think 8 days of statin shouldn't be a problem because this is not like life saving punya, dia perlu maintain kan. So generally, this is from Michigan lah. Yeah, and then others sama juga digoxin, ivabradine, saxagliptin for DM patient lah. Either reduce dose atau whole saxagliptin. But then again, like DM patient, OHA semua tak ganggu, actually saxagliptin saja. Tapi got issue, so if we hold the saxagliptin, I mean whether patients can achieve dia punya sufficient glycemic control during the 8 days or not, kita pun tak tahu. Because katakan we withhold straight away, it's an issue lah. Kalau we reduce the dose still okay, but patient still kena buat SMPG dekat rumah. Kalau dia ada glucometer lah, kalau dia tak ada, then yeah. And then warfarin also lah, lastly. No issue. Kalau on aspirin atau cardiopulmonary tak ada. Yeah, I will share this list juga lah. Yeah. If let's say kalau masa tengah review the patient, you already nampak yang sudah do not use Paxlovid punya, you can straight away cancel lah. The patient tak payah start lah. But kalau tak sure punya, I think still can call the primary team yang tengok the patient to get advice. So it's actually not a straightforward punya medication. This is another drug interaction list based on Liverpool lah. Ini dia by color coding. I will share this also. Dia punya by color coding and symbols. Yeah, this is straight away by the Liverpool Drug Interaction Act. So I think this one, doctors semua boleh download this drug interactions also lah. So kalau pharmacist check also, we mainly use this application. Apple dengan Android semua boleh download. Okay. So I think that's all from me.
Generally kalau yang concomitant medication tu, kalau ubat yang dia on, kalau generally kalau boleh withhold 8 hari tu, kita withhold dululah. Tapi of course if we cannot withhold because we need that medication, then you have to take the effort to call the primary team and ask whether there's an alternative lah. That's it. Tapi generally macam Wilson cakap, kalau macam statin you stop 8 hari, you should have been sure. But of course kalau macam ubat-ubat lain tu lain lah kan, you have to probably think of an alternative.
Yeah, usually high risk patient will on all these common medication. Yeah, that's why.
But generally we are hoping to see younger people with CAT2 lah, CAT2, CAT3 that meets this criteria, so they are generally should have less comorbidity, less medication on lah. Sekarang pun dalam ward mostly they are CAT2, majority CAT2 lah. Tapi because they are admitted because of medical issues, so sometimes it's quite difficult for us inpatient because sometimes they come in category 1 or 2 COVID, tapi they are on oxygen. Sebab katakan CCF, dia overload, so you ada oxygen, then you like kasih pet, yeah.
Sometimes we are sure that in the first 5 days,
So ada juga situation like that. So sometimes it's case to case lah. So kalau if you're really sure patient ni on oxygen sebab heart failure, tapi COVID wise the CAT1, CAT2, then kita try and off the oxygen and then see lah. Tapi kalau is generally if they are requiring oxygen, sometimes for whatever reason, then they are excluded because exclusion criteria they're not on oxygen, even though they're on oxygen sebab CCF or fluid overdose. So,
but normally these patients they will end up in the ward check.
Yeah, they will end up. So kalau they need antiviral, we give them remdesivir rather than Paxlovid because Kalau you nak guna remdesivir macam Paxlovid ni, you can use remdesivir tapi you shorten the duration 3 hari. Kalau you nak treat COVID Cat 4 with antiviral remdesivir, then you give 5 days, 7 days saja. Just that IV a bit mafan lah untuk IV kan. Remdesivir IV. Remdesivir pun dah tak quota dah habis. Remdesivir is more expensive. Okay lah. So boleh start hari ni lah ya. Kan, boleh start lah. Dekat ward pun tak ada lagi so far.
But Dr. Khairul, if let's say the patient is, will be admitted due to other medical reasons, for example, patient is Cat 2, katakan dia masuk MBA, dia kena masuk, for some procedure. So that patient, ED kena start ke atau dia masuk ward dulu?
Kalau masuk ward kita start. Tak perlu you all meant for yang nak discharge. Yang datang, macam, datang sini for whatever reason, then COVID, and then stable to be going home, then you can start here. Tapi kalau yang perlu masuk ward, kita orang start.